Welcome back to Unmute Your Probe, a podcast of the Emergency Ultrasound section of the American Academy of Emergency Medicine. We talk about point-of-care ultrasound, the new research, the controversies, and the modalities that you can use on your next shift. I'm your host, Melissa Myers. I'm an emergency medicine and past president of the AAEM ultrasound section. My guest today is Dr. Joshua Guttman, current president of the emergency ultrasound section, as well as an associate professor of emergency medicine and the owner of Peachtree POCUS. Josh has been a guest on this podcast before, and I'm excited to have him back on to talk about artificial intelligence in point-of-care ultrasound. We'll be talking about how AI might impact education, clinical practice, and reimbursement. Before going any further, I need to give a disclaimer. The opinions and assertions expressed herein are mine and mine alone and do not reflect the official policy or position of the Uniformed Services University of Health Sciences or the Department of Defense. AI is already embedded in a lot of ultrasound systems. I know that I really like the AI VTI calculator that the machines have at one of my places. It saves me a lot of time on shift. I know there's a beeline counter as well. I will be fully honest, I don't really use that one as much because I don't know that I feel like I need it. But certainly I could see it coming. Josh, can you tell us a little bit more about yourself and how you're involved with AI and ultrasound?
I'm an emergency physician. I was coming on this podcast and ultrasound fellowship trained. And I ran the ultrasound fellowship at Emory University, where I am now for a while before moving into consulting and entrepreneurship with Peachtree POCUS. And through that, I've gotten a lot of questions and worked with several companies that integrate AI with point-of-care ultrasound. And so have a little bit of that kind of technological forefront, what is coming lens in AI, but also as a lot of AI is integrated into the handheld ultrasounds as well as the cart-based, I get to having review them all. I have a YouTube channel, the Peachtree POCUS YouTube channel, where I do a lot of handheld reviews and seeing how AI is integrated in these. Also, I have this lens of what's current and future coming in AI and point-of-care ultrasound.
Awesome. So I will be honest, when I started prepping for this particular episode, I realized that I was going to have to do a lot of reading because I am not exactly an AI expert. So I started with this scoping review. It's called Artificial Intelligent Applications for Point-of-Care Ultrasound in Low Resource Settings. And this is by Dr. Kim et al. And the reason that I just want to bring this up is to talk through some of the potential uses for AI, because I think the first question is, how is AI being used? I mentioned a VTI calculator, and so that helps us determine fluid. I think the beeline was probably the first. Josh, can you take us through what are some of the applications we're seeing for AI?
Yeah. So there's just like every point of care ultrasound, AI is split into three. You have your image acquisition, you have your image interpretation, and you have your workflow and operations side. And so there's those three aspects which can incorporate AI. The most developed right now is in the image acquisition and most particular in the cardiac space. And there's a bunch of literature around this, but with embedded within some devices, some might be aware of Caption Health within that GE purchased and was in the GEV scan, but within some other devices as well. Once you put the probe on the patient's chest, it will tell you how to move it around. So AI will then see what is on the chest and then give directions on how to manipulate the probe into getting a perfect cardiac view. So if you are in the educational stage, you're learning how to do cardiac point of care ultrasound, it helps you navigate. So whether you have a teacher or you're in an educational program and you want your residents or students to have more guidance in real time when there's no faculty available, this can do that. Also, there are other programs which gamify it, which allow you to put your ultrasound that has a kind of a cross on the screen and allow you to cross to a different cross. It sounds a little weird, but you basically can just overlay two images on the ultrasound screen to allow you to find the perfect cardiac view. And once you get there, it'll capture your image and it will also grade your images and say, okay, this is a good image, you should save this one. This is not such a good image, and have that percentage like from 0 to 100 on how good your image is. So it has that feedback on how good is your image acquisition skills. And this is most developed for cardiac, but is also there for some other applications as well. For image, then in the image interpretation, that's somewhat of what you found in the beeline counter, is telling you, okay, in this one, like how many beelines are there? There's other technologies which are early FDA or pending FDA approval of telling you if there's a pneumothorax, pleural effusions. There is, for echo, can do somewhat of a read, can give you valvular assessments, can tell you what the IVC is looking like, aortic root diameter, some of those things that we already do by doing a basic point of care ultrasound can interpret those images and actually go beyond what you might do in a basic POCUS to give you information that you wouldn't get otherwise. There are applications that assist with obstetrics in fetal dating and station. There's different AI applications for needle guidance to tell you where your needle is and your directionality that you should go. And it's gotten all the way to some devices that are both pre and recently FDA approved and actually automating ultrasound completely. And someone just puts a probe, or there's a robot arm that puts the ultrasound probe on the patient and automates it completely, where you don't even need to have a user be able to do it. So that's super point of care where you're taking the image acquisition out. So I went a little bit from image interpretation acquisition, but then as an operations standpoint, this is in development. There's nothing currently out there that does this, but some of the future is looking how to do auto QA in you're saying the interpreter says, okay, this image is good. And then AI will say, yes, the interpretation is correct. And to have that auto QA and real-time feedback for the sonologist, the person doing the ultrasound, but also helps decrease, for example, faculty time, where it's expensive and time consuming for faculty to do QA on every image. But if a resident says this fast is negative and the AI says this fast is negative, that may not need to go for formal QA review with the faculty, where in the case there's a discrepancy, or perhaps only the positive ultrasounds can get reviewed by an expert. So that's in short a lot of where the current and future landscape of AI and POCUS is.
Yeah, I think there's a lot of potentially valuable applications there. I do have a little bit of hesitance. So when I looked at the scoping review, they mentioned I think almost everything you just talked about. There was a lot of talk in this. It was 29 separate studies, most of which were done outside the United States, so used applications that might not be available here. And it was a lot of, fetal measurements, a lot of cardiac, a lot of pulmonary. And the authors are advocating that AI could be useful. So if you have a clinician and they're performing an exam and they, for example, maybe don't know how to do fetal dating, and the machine can do it for them. But I worry a little bit, right? Because if I use the auto VTI, and I keep throwing this out there, so VTI, velocity time integral,
Yeah,
but it allows us to look at blood flow across valves such as the aortic valve, and we can use that to infer the fluid status of the patient. I use the VTI calculator. I also know how to do a manual VTI. And so if I ever get a number and I'm like, I don't know that number looks right to me, or that, the waveform this machine is drawing does not look right to me, I know that I can go back and I can fix that. And I worry a little bit if we start throwing AI tools out there and people are using them who have never been trained in how to do that modality manually, that if the AI gives us weird numbers, they won't know that it's a weird number. Do you see that happening, or do you think there's a way that we could put safety rails around that?
it's a very important concern, and even current AI applications, physicians who are using it need to understand how to do it also. And this could just give you a little bit of additional information that you already have, but you need to get a sense of what it's looking. Where I see this, and so I share that concern, and it's not like I don't think removing the physician completely out of it, but what you can do is it's much easier. For example, the image acquisition is the most difficult part of point of care ultrasound. So if you can remove some of that image acquisition difficulty and the cost and time it takes to train someone, it's much easier to train someone to do image interpretation. And this is something that could even be done virtually. Testing can be done virtually. So as long as they know this is what it's supposed to look like, it's a much lower bar, especially with the limited applications we are using, versus like, how do you get a great image and put a great image into the AI? If the AI can do that more or less itself, a physician can look at it. And I'll give you an example. When we look at the heart and we look at cardiac contractility, we don't typically assign a specific ejection fraction. We might guesstimate, or we'll put it into categories in the point of care. This is normal, this is mildly decreased, moderate, severe, standstill, hyperdynamic. What an AI will then do, an AI can give you a number. Cardiologists like numbers. A lot of non-acute care clinicians like numbers. But you need to be able to look and say this number makes sense. So where you say, oh yeah, this is pretty low, and the AI says 15%, you're like, okay, that kind of works. And that makes sense. Or this tracing is good. And so this output seems right. It's much easier. I can teach someone in 15 minutes how to look at a VTI and say that their tracing is correct, but to teach someone how to get an apical 5-chamber view, put the pulse wave Doppler there, press the pulse wave button, but mostly how to get the apical 5-chamber view is the more difficult aspect. And AI will assist in the more difficult parts, create objective numbers, but with some oversight and understanding it's correct. And from a medical legal standpoint, that's still the standard practice. And beyond that, right now, there's some bills in Congress which might change this, but currently, the physician needs to interpret in order to bill for that ultrasound. And so it can't just be AI said this, AI said that. It has to say, I looked at it. The AI added some values which are valuable. It was able to do it. It didn't look like the aortic valve was opening and closing, and it added a value that there was no aortic stenosis, or it added an EF, or the RV looked okay, but the fractional shortening of the RV or the fractional area change was read by the AI as normal, and that sort of jives with what I'm looking at, and then I get this sort of echo report that's sort of spat out, but it does need to have both aspects of it.
To still have that physician oversight and understanding of the test.
Yes. And, AI, I was asking outside of ultrasound, like I asked both open evidence and up-to-date AI the same question regarding what antibiotic choice is, and it gave me two different answers. So again, it needs someone who's trained to say, okay, what sounds right to me? You know what I mean? It'll never take the human out of it, but is an improvement. If it can help me get a better cardiac view and tell me when I have a good cardiac view, the interpretation becomes easier. If I say, oh, here's a bunch of B lines, but I want something objective, or I say, okay, I want kidney labeling and kidney, and I want fast labeling to say upper quadrant, left upper quadrant, and the AI, this already can happen, will just label it for me because it can see it, and that helps with my workflow, then great.
Yeah, and I think something that you brought up when we were preparing for this was the idea of AI in education, which is not something I know that I had considered particularly deeply and probably should have. You sent me a pre-publication article that you've written, and I thought it was really interesting because, yeah, I'm aware that there are machines out there that will label for you. I know that there's one that labels the chambers of the heart, and I think we're working with students that would probably be very useful. I know my medical students right now are learning the point of care limited echocardiogram, so I spent about 2 hours yesterday with my teaching assistants working through this. And yeah, learning the chambers is always very challenging. And I think having labels on there is probably very helpful. But one of the things that you brought up in your article I thought was really interesting was using AI in education and then slowly removing that scaffolding as the learners advance so that it doesn't become something that they can't function without. Can you tell us a little more about that? Because I thought it was a really great approach.
Yeah, and I think about it a little bit like we have video assisted laryngoscopy, and everyone knows you also have to learn how to do direct laryngoscopy because, what if the video isn't working? There's technological issues that comes about. So you have to have the skill to be able to do this without that help. But when AI is implemented from an educational standpoint, it has many benefits in less faculty time. You can have students come in on their own. They learn once and then they can bring it to the bedside and get some assistance if they don't have a faculty member there on how to move the probe, how to turn, how to label the images. And so faculty, you don't have to pay as many faculty to be there and have as hands-on. You can actually scale this quite a bit for a lot of students, but what I mentioned in the article is that you have to be careful and you have to be deliberate because you can create dependence and we're seeing that in global LLMs and using in students where there's complaints that people aren't thinking as much, aren't doing as much if ChatGPT can do it all for them. And so we have to be careful when we implement it that they're not only can do it with AI, but can do it without AI. And so what I suggest is that you have AI for early on in the rotation, or you do it initially with AI for if it's a 4-week rotation, initially with AI for a week, and then take away AI and see what they can do. And then as they struggle, you can bring back AI in the week later. And finally, when they're getting their testing, that they don't need AI anymore. It has to be this thing where you can remove it and they still have the skills to do it. They have to be able to do the math without a calculator, even though and it's possible in the future that we won't need to. But at least at this point, you want to know that they can do the skills without AI because they might use a machine that doesn't have it, or it might not be working, or even beyond that, what we talked about the physician oversight, you need to be able to do it yourself to be able to get that and understand that physician oversight.
Mhm. Yeah, I think it just really caught my attention because our last episode of Unmute Your Probe, we had two medical students come talk to us about their experiences with ultrasound and education. And one of the themes that came up a lot was the desire for a lot of one-on-one faculty time. And so it almost wonder if we could use a graduated approach where I teach you and then you go off for practice for 2 hours with feedback from this AI system, and then you come back and then I teach you some more. And that way you're getting that more individualized feedback. So
I,
definitely.
I 100% agree. It scales. Faculty are expensive. There's less money going to education these days. And so we have to use the tools that are out there to assist our students. I don't believe AI can teach someone how to do point of care ultrasound. It can't help move someone's hand. It can't move a person's hand. It is not expanded to every indication that we do. It certainly can't do a gallbladder or an aorta just yet. You need someone to show you how to put the probe on, how to approach the patient, how to discuss what a point of care ultrasound is with your patient. But you need someone to show you at the beginning. Once you start to get a little bit comfortable, you can go off and get your reps in scanning. And if you're not sure what you're doing, you don't need that one. You need less of that one-on-one time that's being assisted by the AI. But then as you have this spaced repetition, which is a thing within education where you teach and then you let them do, and then you come back and teach it again, they're going to gain a lot more from that second go round with the faculty member. And they're like, oh, I did this, but the AI said this, and then I've had trouble with this. And they really have that immediate feedback, but also gets that they get more benefit out of that second go round with the faculty member.
Yeah, so not a replacement anyway, but potentially a really useful adjunct tool, I think.
Yeah. Yeah.
So the last thing that I wanted to get into here is AI. I think we've talked about there's certainly some use cases for this. And frankly, I think it's something that we're going to see. It almost reminds me of when I was in residency and free online medical education was new. And I remember a lot of my faculty being very uncomfortable with it and wanted me to use only textbooks. And me being the intern that I was like, I'm not going to do that. And you can't make me. I don't know if that was a great educational approach on my part, but it does take me back, right? Because my students are using Consensus and they're using OpenAI. And I am not comfortable with these residents coming to A on shift and asking it for questions, but I also don't think I can stop them. They're going to continue to do this. And so I think when we look at AI and ultrasound, we're going to see this come. It's going to be a part of our practice. And so I really appreciate you coming on today because it gives us a chance to talk about how are we going to incorporate this. The last paper that I want to briefly touch on is titled Artificial Intelligence in Point of Care Ultrasound Benefits, Limitations, and Implications for the Future. And this is by Karian et al. And they talk about a few things in here, many of which we've touched on. The idea that if we're using AI, it needs physician oversight, that it would need an understanding of the test. It's not going to replace physician clinical reasoning. One thing that this paper brought up that I thought was really interesting is the idea that AI is trained on data sets. And please stop me if I'm saying anything incorrect here, because I am by no means an expert. But I do understand it's trained on data sets. I take data and I feed it into this algorithm and it creates the
Right.
algorithm. So if that data set's not representative of the patient population, then we run into these potential issues. And I noticed in that scoping review we talked about earlier, it looks like a lot of this data is being done at single center, probably by experts. And so I wonder if we might even see some kind of justice or equity issues where we have this great algorithm and it only works in this one set of people and I can't generalize it, or patient safety issues if we're trying to generalize an algorithm. And then taking that one step further, if we see companies doing this, presumably those data sets would be proprietary. So there wouldn't be a good way to tell if I could generate that out, like use that algorithm on my patient. And I just was wondering if you had any thoughts on that.
Yeah, so 100%, it's a concern. I was giving a talk on POCUS and AI about a year ago in a global health conference, and this very question was brought up during a panel of one of the speakers as well. There's, these tools were not looked at, were not tested on the low middle income patient. And, how does that limit? Is there a question of its applicability? And so it's a good question. And part of me, and just to get into your other question about companies that are using these data sets, they're typically partnering with large universities. And so their data sets are coming from, in fact, Mayo Clinic has this whole program where they partner with AI companies to provide some of the ultrasound or other data sets and utilizing and then helping incorporate. So a lot of these but they're expert read, and these data sets that are coming from academic medical centers a lot of the time. But I guess to me, it comes down to the question. I think with ultrasound in particular, I think if it comes down to if there's a difference in population in how it manifests, if a heart looks different in someone from, rich area of the United States or a first world country versus someone from a lower middle income country, I think that does make a big difference. What I wonder is if a heart looks like, if CHF looks like CHF on an echo, regardless of where you are, and I think we would know this already, then I think it may not make too much of a difference and still be applicable, although I certainly see where they're coming from, but more what you do with this. I think the differences in these populations are what you do with this data, how you treat them, what medications tend to work better, what's better in different races and other populations about how you apply this to the patient in front of you. So I see less of an issue with point of care ultrasound in AI, but it certainly is something important to think about. Some companies, Butterfly, for example, does keep a lot of their images in proprietary mode, so that it's not that no company does the companies only use data from academic centers. So it's definitely something concerning, and I think as it's applied in practice, I think it will bear out if this is something that's helping patients or not. But it's certainly, like, I can't sit in here and say this is not a limitation, but at the same time, I feel personally that I think that what an organ looks like under ultrasound and how, a free fluid in the abdomen, I'm not aware of any differences in population differences on how that's looked at on ultrasound. But if that were the case, knowing what we already know about ultrasound, that's something that would be a limitation in applying it to different populations, just like any other data we use.
Yeah, almost like medication moving from clinical trials to population. Sometimes
Yeah.
things come out. All right. As we come to the close here, I think my current thoughts on AI, and I'm curious to see what you think about this, is I think this could be really useful to us, but it's something that I think we have to approach like we would any other test. Like we have to understand what we're using and why we're using it. We have to be deliberate about it. I think, at least for me, I like the idea of having, AI feedback for students. I think that it could potentially be helpful, but I'd want to know exactly what feedback they were getting. I'd probably want to watch it for a while to ensure that I think the students are getting the right feedback. And then same with the clinical calculators, but at the same time, I don't know that's different than any other test that I order, right? If I get a new lab test at my hospital, I'm going to want to know the sensitivity and the specificity, and I'm going to need to think through how I'm going to incorporate that in my clinical practice. And so I think, to me, AI is like that. I don't know that I see it as being fundamentally different than other tests that we use. And I'm curious to see what you think.
I would expect nothing less. I expect, if a good educator, just like if you're going to get even non-AI, if you're going to incorporate ultrasound simulators into your ultrasound training, you're going to try out the simulator and see that it's good quality before you purchase it, and before you apply it to your students. You want to see modules. You want to see that it provides quality imaging, and that goes with any educational tool that you're going to implement. If you're going to subscribe to a question bank and give it to your residents or students, you want to be able to know that these are good questions, that the answers are quality. So it's no different. And I like your analogy with the new lab test, because I agree. And I had thought about the high sensitivity troponins, which those of us who are old enough, who are, a good amount of time out, and be able to to remember that we started with high sensitivity troponin. So like these were coming, and we had to learn how to incorporate it into our practice. We understood what the algorithm said. We followed an algorithm, then get a sense of what these numbers mean and how to incorporate it. And I think as AI becomes more integrated, and just like in the ambient listening scribes, a lot of us are using those now, and we are learning on the fly what we like and what we don't like, and mistakes that it makes, and how we can incorporate it. It's all the same thing.
Yeah, I agree. Thank you so much for coming on the show today. I think this has been really interesting. I'm excited to send this episode out into the world for folks to listen to. This has been Unmute Your Probe. This is a podcast of the emergency ultrasound section of the American Academy of Emergency Medicine, and thank you for listening.